All right, so we'll move on to the second in our Chief Point Counterpoint series. Today we have two of our rising chiefs, or I guess current chiefs, but rising sevens, Alejandro and Jeff, who are going to be talking about mid-sized acoustics and the decision of whether to use radiosurgery or resective surgery to treat these lesions. As all of you know, Alejandro hails from first the University of Alabama and then University of Pennsylvania, where he attained his MD. And Dr. Zimering over here went to Cornell for undergrad and completed his MD nearby down the street in Rochester. But as I pointed out, our last Chief Point Counterpoint was really a street fight, if you will. I think of this one more as a matchup of highly tuned athletes, finely chiseled, trained, and they've reached a pinnacle in their careers, and so now is an opportunity for them to show their skills and figure out who should rise to the top.
Wow, what an introduction. Well, thank you. I'll go ahead and share my screen and begin this match. Okay. So we're going to be talking about vestibular schwannomas and the various options, focusing on surgery versus radiations for small to medium-sized schwannomas that have been determined to require treatment. Before we dive into the details, I want to begin with a little bit of an introduction. First of all, there's no conflicts of interest. Why are we having this discussion today? Well, because there is no consensus on the gold standard treatment for newly diagnosed small to medium sporadic vestibular schwannomas. That being said, we do have quite a bit of evidence detailing some of the outcomes, some of the benefits between treatments. And so we want to dive into that and discuss microsurgery versus radiosurgery. As far as a background, so the diagnosis of small vestibular schwannomas has increased over time because of improved imaging and diagnostic techniques. So as magnetic resonance imaging has improved, as audiograms and the availability of diagnostic techniques has become more widely available, we've diagnosed more and more of these small vestibular schwannomas. According to this source, over time, that's led to a trend towards an increasingly conservative approach. A recent retrospective analysis of the SEER database revealed that the rate of vestibular schwannoma managed by means of watchful waiting has increased over time, particularly in older patients and those with smaller tumors, and predicts that by the year 2026, approximately half of newly diagnosed vestibular schwannomas will be initially approached with observation alone. So what about their natural history? Okay, if we decide to simply observe vestibular schwannomas, well, vestibular schwannomas have on average a growth rate of about 1.4 millimeters per year. Large retrospective analyses suggest that tumor control with observation alone is 65%, and serviceable hearing can be expected to be about 71% at 2 years. And it's important to consider that neither surgical resection nor radiation restore any lost hearing and carries with it the risk of further neurological dysfunction. So you're balancing tumor control with further neurological dysfunction. Observation may be considered in patients with small tumors, patients with multiple medical comorbidities and no growth of the tumor and stable symptoms. But hearing loss can occur with observation, even regardless of tumor growth, and that's because of compression of the neurovascular structures. And retrospective series have demonstrated that patients who underwent observation for schwannomas declined from 70% of diagnosis to 31% over a long period of time of 10 years. So in a recent systematic review, try to identify factors that could lead to personalized management of this vestibular schwannomas. And it notes that of note, tumor size is not among the factors dictating treatment versus observation. However, larger lesions have higher probability to cause symptoms. But somewhere between 58 and 71% of small vestibular schwannomas are stable in size. And most authors suggest adopting a watchful waiting approach for small asymptomatic lesions and begin active treatment if there's tumor growth greater than 2 to 3 millimeters per year, so more than average tumor growth, and or significant worsening of symptoms. However, since we're going to be discussing tumor size, I should note how we grade and consider tumor size of vestibular schwannomas, and there's two commonly used grading schemes, but perhaps the most common is the Coues grading classification, which is just 4 categories of grade 1 being the smaller, just simply intracanalicular lesions, grade 2, where these lesions now extend into the cerebellopontine angle, grade 3, when they begin to make contact with the brainstem, and grade 4, when they actually cause displacement of the brainstem. And while we're discussing scales, one very important outcome in vestibular schwannoma treatment is hearing preservation, and the Gardner-Robertson scale grades hearing function, where grade 1 is excellent speech discrimination of 70 to 100%, and as you get to the higher grades, you get to lower hearing ability or more hearing loss. So in thinking about specific treatment approaches, I just want to talk about surgery in general for vestibular schwannomas, not necessarily in one specific size category, but overall, a lot of sources will say that surgical resection is indicated for patients with large tumors. Some say more than 3 centimeters, some say more than 4 centimeters, as well as recurrent tumors after radiotherapy. Those with brainstem compression, again, the Coues grade 4 tumors, those with cranial neuropathies or with hydrocephalus. Complications of surgery include CSF leak, maybe around 10%, headache, trigeminal or facial neuropathies, hearing deficits, hematomas, hydrocephalus, aseptic meningitis, and hemiparesis. A large review of 1,000 vestibular schwannoma resections noted 98% complete resection rate, with a 68% hearing preservation rate and about a 1% rate of mortality. If you're able to achieve a complete resection, the local recurrence rate is very low. Therefore, surgery with a complete surgery, first of all, in this large series led to 98% complete resection rate, and of those, only a 0.2% of those had local recurrence. However, if a subtotal resection is achieved, then there's approximately a 30% rate of regrowth. This is derived from the Stat Pearls the Stat Pearls article that you can find online regarding vestibular schwannomas, and it is a resource that is available to the general public, and this is talking about vestibular schwannomas in general, not regarding size, but I want to mention some of the things that they state. So a retrospective comparison of microsurgery versus SRS suggests that local rates are comparable. Facial and trigeminal neuropathy rates were higher with microsurgery. Hearing preservation was significantly higher with radiosurgery. And perioperative complications and length of hospital stay were longer with microsurgery. So overall, they point towards radiosurgery. However, that's what we're here to argue today. And I will point out some evidence that suggests that that is not always the case. For example, this is a more specific meta-analysis, came out in 2022 regarding small to medium-sized sporadic vestibular schwannomas. And it pulled a number of different studies regarding these small to medium-sized schwannomas. It found that tumor control is in fact it's similar. However, there was a statistically significant difference. Microsurgery having a higher rate of tumor control, defined as arrest of tumor growth and or decrease in tumor volumes, and so 98% of these in microsurgery versus 92% in radiosurgery, with a similar follow-up of about 70 months. When it came to hearing preservation, there was no statistical significance between microsurgery and radiosurgery, with 56% hearing preservation achieved in microsurgery versus 59% achieved in radiosurgery, with a follow-up of about 65 months. And in terms of facial nerve dysfunction, however, there was a statistically significant difference here, with radiosurgery having a lower rate of new or worsening facial nerve dysfunction of House-Brackman grade 3 or more. So only that was seen in 2% of radiosurgery cases versus 10% of microsurgery cases. So we see that for these small to medium vestibular schwannomas, there is statistically significantly better tumor control, however, with a slightly higher rate of, albeit statistically significant, facial nerve dysfunction. This is a separate meta-analysis that came out in 2022 as well, and it looked at vestibular schwannomas of all sizes. However, this is an interesting table which separated those vestibular schwannomas in terms of size. We can see that in this systematic review and meta-analysis, the pooled odds ratio of hearing loss in small to medium vestibular schwannomas was actually lower than that of hearing loss after radiosurgery. So in the small to medium category, in this meta-analysis, radiosurgery led to higher odds ratio of hearing loss as compared to microsurgery. That is different than for large vestibular schwannomas in, I'm sorry, in this one, large vestibular schwannomas also had a higher rate of hearing loss with SRS. However, when you mix all the vestibular schwannomas that they looked at, there is a fairly similar rate of hearing loss, that of SRS having a wide, much wider variability. When looking at facial symmetry and loss of facial symmetry, small to medium vestibular schwannomas here also had, perhaps surprisingly, a lower pooled incidence of loss of facial symmetry after surgery as compared to SRS, which had a higher rate of facial symmetry. So we are seeing some conflicting evidence here. When they combined all the vestibular schwannomas across groups, there was a higher incidence of loss of facial symmetry in the microsurgery group, but you see that for the small to medium size vestibular schwannomas that we're focusing on today, that wasn't the case in this meta-analysis, and loss of facial symmetry was actually higher in SRS cases. There aren't many guidelines on vestibular on the treatment of vestibular schwannomas, and as mentioned earlier, there is no gold standard treatment. However, these are guidelines that were put out by the European Association of Neuro-Oncology in 2020, and it summarizes its guidelines into these 5 points. Those are that observing vestibular schwannomas is considered appropriate for incidental asymptomatic lesions. However, it mentions that SRS may be performed for these as well for tumor control. For smaller vestibular schwannomas where preserving facial nerve and hearing function is primary goal, they suggest SRS over microsurgery may be chosen. Again, it's not a strict rule, but it is a suggestion based on their compilation of evidence. In large vestibular schwannomas, surgery is considered primary treatment to reduce mass effect. And the choice of surgical approach depend on the tumor's characteristics and surgeon's expertise, with neurophysiological monitoring being mandatory. Also, for large vestibular schwannomas, tumor mass reduction followed that after surgery, followed by SRS or observation, is a valid option. And any residual tumor volume, as we know, will be a risk for tumor regrowth. These guidelines further divided their recommendations into size as well. So for small asymptomatic tumors, they note observation versus SRS is reasonable. However, they also state if long-term preservation of nerve function is the primary aim of management, even surgery can be chosen. However, the risk of any functional deterioration is considerable, ranging up to 50%. And this was class 3 evidence. They recommended against surgery here with level C evidence. For small tumors with impaired hearing, they thought SRS offered a better rate of hearing preservation and a lower risk of facial paresis, and this was a level C recommendation. Once these small tumors reach complete hearing loss, the aim of therapy here can be cure or motor control while preserving facial nerve function. And all options are justified in these cases. For medium-sized tumors, now Coos grades 3 or 4, surgery or radiosurgery can be recommended at very similar levels with a level C recommendation. And once we reach large tumors, Coos grade 4 greater than 3 centimeters, then the primary goal is decompression of the brainstem, as well as stretched cranial nerves, and that makes surgery the only option. Well, what about lifetime cost, as well as quality adjusted life years? Well, there was a study done on the lifetime cost and the quality adjusted life years across management, specifically for small and medium-sized sporadic vestibular schwannomas. And it found that across all ages, the most cost-effective strategy for treating smaller, medium-sized sporadic vestibular schwannomas was observation with subsequent radiosurgery reserved for tumor growth. And so here, you see if the age of diagnosis is 18 years, just an example of how cost does increase as you go from, radiosurgery reserved for only tumors that are growing versus surgery for tumors that are growing versus upfront radiosurgery versus upfront microsurgery. And the quality life adjusted years were almost had an inverse correlation. with higher quality adjusted life years for, radiosurgery for those tumors that showed growth, and lower numbers for those that upfront microsurgery. And then they looked into this for patients diagnosed with these small to medium sized sporadic vestibular schwannomas at different age groups. And they found similar results across age groups. Just to skip forward to their higher age demographic, age of diagnosis at 70 years, you see a similar trend of cost as well as quality adjusted life years. However, I think that piecing all of this evidence together really depends on the patient, the tumor, their symptoms, and I think it's interesting to see that even meta-analyses, which compile and analyze data from many studies, will have differing results. And this one in particular was really interesting, showing some benefit of surgery for the small to medium-sized tumor category. So with that being said, I'll throw the ball over to Jeff, let him discuss things from his angle, and then maybe we can further discuss afterwards.
Thanks, Alejandro. So before the debate, I got a text from our program director who said, don't forget, the answer is always surgery. However, this morning, we're going to examine the proposition that for intermediate sized vestibular schwannomas, the answer may actually be radiosurgery. As Alejandro had mentioned, there's two major grading systems, the KOOS grading system, as well as the Hanover classification scale. But here, just to reiterate, is a pictorial representation of the KOOS grading system. And our focus really is on grade 2 and grade 3 sized vestibular schwannomas, where in grade 2, you have the tumor that starts within the IAC and extends into the CPA, although there's no contact with the brainstem. And in grade 3 tumors, there is contact with the brainstem. However, there's no overt compression. And here with the Hanover classification scale, it's similar in that it discusses IAC as well as both intra and extra canalicular extension, as well as brainstem compression. However, they just have a few more subtypes, but our focus is really in panel C and D here in terms of the size of the lesion. And again, for facial nerve function and hearing preservation, these are the two scales. The House-Brackman grading scale for facial nerve function, where a House-Brackman score of 1 is normal facial nerve function. And commonly to differentiate a grade 3 versus 4 House-Brackman score, oftentimes denoted by incomplete eye closure, which defines a grade 4 House-Brackman score. And then for hearing preservation, the two major scales, the Gardner-Robertson, as well as the AAO-HNS, for class A, B, and class 1 and 2, these denote serviceable hearing, speech discrimination at least 50%, and pure tone averages from 0 to 50 decibels. So there are basically three major radiosurgery technologies: gamma knife, linear accelerator, also called LINAC, and proton beam therapy. So the gamma knife uses cobalt as a source of emitting gamma rays. In this technology, the equipment does not move. With the linear accelerator, also terms you may have heard, such as CyberKnife, X-Knife, Novalis, Peacock. This uses high energy X-rays and the machinery actually moves around the patient during the treatment session, and also used for external beam radiation therapy. And then lastly, proton beam therapy is a different technology that uses particle beam radiations and uses particles, in this case, protons rather than gamma or X-rays, and a closer control of radiation dose at a greater depth is achieved due to the heavy charge nature of the proton particle. So here you can see in this graph, the proton curve, which is shown in blue, deposits most of its energy at the end of its path at the tumor, with then a steep drop off. This is called the Bragg peak. Whereas the photon that you see in red, this would correspond to X-ray or gamma rays. It deposits its radiation close to the surface and then maintains this exit dose after reaching the tumor. So there's controversy in the literature regarding the best treatment option for intermediate-sized vestibular schwannomas. The CNS published an evidence-based guideline on hearing preservation in these tumors. The guideline committee addressed the probability of maintaining serviceable hearing at 1, 5, and 10 years after single fraction radiosurgery in adult vestibular schwannoma patients. And the target population was adults with serviceable hearing ipsilateral to the tumor before treatment who received less than or equal to 13 grays of radiation to the tumor margin. The CNS committee members screened and assessed over 1,300 studies, of which 47 met criteria for inclusion in the systematic review. The median dose was less than or equal to 13 gray to the tumor margin. To be included, a study needed a minimum of 20 patients with median follow-up of at least 2 years. So the guideline reported that adult vestibular schwannomas treated with a single fraction of SRS had 50 to 75% hearing preservation at 2 and 5 years post-treatment. And the level dropped to 25 to 50% 10 years post-treatment. On the other hand, adult vestibular schwannomas treated with microsurgery had lower hearing preservation rates at 2 and 5 years after therapy. In a subset of patients who present with Gardner-Robertson grade 1 hearing at baseline, the early rate of hearing preservation is even better with single fraction SRS, 75% to 100% at 2 years post-treatment, 50 to 75% at 5 years, and 25 to 50% at 10 years. The hearing preservation rate at 2 years in this subset of patients was better for radiosurgery compared to microsurgery, but was no different at 5 to 10 years post-treatment. The guideline committee next asked the question of what patient or tumor-related factors may affect progression to non-serviceable hearing. Evidence was judged to be level 3, which denotes unclear clinical certainty, and significant factors including good pre-op word recognition and pure tone thresholds, smaller tumor size, and marginal dose less than or equal to 12 gray, cochlear dose less than or equal to 4 gray, and notably neither age nor sex was a predictor of hearing preservation outcome. In summary, most of the class 3 evidence leads to the conclusion that the risk of hearing loss increases well past the initial 2 years, and at 10 years, only a third of patients maintained serviceable hearing. Dr. Germano and her co-authors published a CNS guideline that addressed the role of radiosurgery in vestibular schwannomas. They evaluated the evidence of SRS versus observation in intracanalicular vestibular schwannomas without progression. But based on level 3 evidence, they recommend that if tinnitus is not present and a tumor is either confined to the intracanalicular region or less than 2 centimeters, then it can be observed without any adverse impact on tumor growth or hearing preservation compared to treatment. Dr. Germano's group also looked for studies that addressed outcome differences among gamma knife, LINAC, or proton beam. There were no studies that directly compared 2 or all 3, and thus no firm recommendations could be based on level 2 evidence. However, in a comparison of individual studies, it was apparent that rates of facial nerve and trigeminal nerve dysfunction were similar for both LINAC and gamma knife radiosurgery, and proton beam was associated with lower hearing preservation rates. A dose less than or equal to 13 gray was associated with good tumor control and minimal side effects. Next, I'd like to examine two studies that directly compare microsurgery to radiosurgery. The first is from Pollock and co-authors that was published in Neurosurgery in 2006. In it, they compared small to medium-sized vestibular schwannomas having a diameter less than 3 centimeters. There were 82 patients, 36 were treated with surgery, and 46 with radiosurgery. Mean follow-up time was 42 months. Normal facial movement and hearing preservation rates were higher in the radiosurgery versus surgically treated group. They concluded that radiosurgery was superior and best management strategy for small and medium-sized sporadic vestibular schwannomas. The baseline characteristics in patients treating with microsurgery versus radiosurgery, the groups only differed in baseline age. The microsurgery patients were significantly younger. However, there were no differences in baseline tumor size or the proportion of patients having baseline serviceable hearing or facial nerve dysfunction. There were statistically significantly higher rates of preservation of serviceable hearing in the radiosurgery versus microsurgery treatment groups at 3 months, 12 months, and at the last follow-up visit, which had a mean of 42 months post-treatment. At 3 months, 12 months, and the last follow-up, normal facial movement was experienced by a significantly higher proportion of patients that was treated with radiosurgery compared to surgery. CSF leak was a significant occurrence in the microsurgery group, affecting 5 of the 36 patients, and 2 patients who underwent radiosurgery later required surgical resection for regrowth, but the overall tumor control rates between radiosurgery and microsurgery were not significantly different. Quality of life measures declined early in the microsurgery treated patients, including physical functioning, energy fatigue, and overall physical measures. And at 1 year, there was still a significantly greater decline in physical functioning in the microsurgery versus radiosurgery group. The second study, which undertook a direct head-to-head comparison of radiosurgery that used Gamma knife to microsurgery, was reported by Meisreth and co-authors in Neurosurgery in 2009. They treated a total of 91 patients with vestibular schwannomas having a maximum diameter of 2.5 centimeters, and 63 patients had Gamma knife and 28 patients open microsurgery. The baseline clinical characteristics, including hearing function and facial nerve function, did not differ significantly between the treatment groups, and mean tumor diameter in the CP angle was also not statistically different. As shown in the diagram to the right, a significantly higher proportion of patients treated with Gamma knife had preservation of hearing at 1 and 2 years post-treatment compared to the surgically treated patients, nearly all of whom experienced profound loss of hearing at 1 year and 2 years after surgery. House-Brackman grade 1 facial nerve function was substantially preserved in the Gamma knife treated patients at both 1 and 2 years post-treatment. However, it declined substantially in the microsurgery treated group, and the differences were statistically significant. Now, proton therapy is also available at specialized centers. It allows delivery of higher doses to target tumor sites with lower exposure to the surrounding healthy tissues. Kukler and others evaluated local control and complications in 261 patients. This included 149 patients that were treated with either SRS or hypofractionated stereotaxic radiotherapy, 87 patients that received fractionated radiotherapy, and 25 patients that received fractionated proton therapy. The median follow-up time was 38 months. So as you can see from this slide, this shows the Kaplan-Meier survival curves for hearing preservation for each of the different treatment modalities. There were no statistically significant differences in preservation of hearing at 24 to 48 months post-therapy, and the hearing preservation rates were 75% or higher for each individual modality. Local control of tumor growth was examined at intervals up to 10 years following treatment. There were no significant differences between the modalities, and the overall rate of control at 10 years that was noted for this fractionated radiotherapy treatment group was 80%. New facial nerve and trigeminal nerve abnormalities were significantly more likely to occur in the fractionated proton therapy group compared to all other groups. In this particular study, fractionated proton therapy tended to be used to treat large tumors that were having brainstem compression. This finding may have been due to selection bias rather than actual toxicity from the fractionated proton therapy. A recent study from Roos and co-authors stratified vestibular schwannomas according to their Coos grading system to test whether a larger size vestibular schwannoma may be associated with different outcomes. Here you can see the AP and lateral diameter of the tumors decreased in both the Coos group A, which corresponded to grades 1 and 2, as well as the Coos group B, which corresponded to grades 3 and 4 sized tumors. The group B tumor had minimal or no brainstem compression. There were no significant differences in tumor control, hearing preservation rate, or toxicity-free survival in the Coos group A or B tumors that were treated with LINAC. Loss of tumor control occurred in only 5% of patients, and the tumor control rates were 98% at 2 years and 90% at both 5 and 10 years. In this multi-center trial that was using SRS in neurofibromatosis type 2, 267 patients harboring 328 vestibular schwannomas were treated in a single session. The tumor control rates at 10 and 15 years were 77% and 52%. Serviceable hearing was preserved in 64% and 35% of patients at 5 and 10 years. Although there were no reported cases of malignant transformation, according to the CNS guidelines group, this can occur in about 0.3% of treated patients. So in summary, SRS was superior to microsurgery for intermediate vestibular schwannomas because it resulted in greater preservation of hearing and facial nerve function. The greatest differences between radiosurgery and microsurgery occurred in the first 2 years after treatment, and after 10 years, there were no significant differences. Since vestibular schwannoma is a slow-growing benign tumor, you have to weigh the benefits of preservation of function, which may be equally important as tumor control. Thank you.
Let's open it up for discussion. If anybody has any comments, this is obviously a controversial topic within the skull-based field. So really looking forward to some heated discussion.
So I can start comments. I think, I'll just start. The very first thing I want to say is the quote about surgery is always the answer was taken out of context. The question was about, I think, T10 to pelvis, if I remember correctly. So that's an out of context statement. But regardless, there's no question, I think, that radiosurgery is the preferred way to treat the small, I would call them Gardner-Robertson class A vestibular schwannoma. So you have a small tumor that has good hearing, in which you have good hearing. There's no question about radiosurgery being the better treatment option. There's a few points, however, I want us to remember just collectively. So Konziolka recently reviewed what we think of as natural history for vestibular schwannomas. And when we look at following tumors and we keep measuring size on MRI, we have to be mindful of the fact that a better indicator of size is really volume. Collective volume may be the better way to really follow tumors, because if you look at 3D volumetric, it's probably a more accurate representation of growth. So that's number one. And I think it's important because even ourselves, when we look at follow-up, if you look at them incrementally over 10 years, you'll see a different pattern of growth versus if you just compare it to the last year MRI. And that's true for a lot of benign tumors. So that's one thing that's important to consider. The second thing too, I think, is what do you do for, like you described as Coos grade 3? So these are the patients who are symptomatic from their size of their lesion, clearly have growth that affects the CP angle. And I think there are two big studies which I use as an index case when I think about one. You can never do complete randomized control for this because it's just hard to randomize control. But if you look at matched cohort, so matched cohort, they're too big. There's the Mayo study that Matt Carlson did, which was about 2016 or so. And then Golfinos and Kanzioka reviewed their internal series about the same time, maybe a year or so earlier. And what they found is basically what both of you have kind of summarized and said. In the short term, for these kind of, I call them Coues grade 3, this intermediate sized tumor, there's no question you're going to see improved outcome with radiosurgery, right? Because you're not operating on these patients. So facial nerve preservation, hearing preservation is different, no question. I think what's really interesting is two things. One is if you look past 4 to 5 years and then you look at 10 years down the road, all that starts to normalize, right? Because there's no treatment that's going to preserve hearing in the long term. So that's number one. And then number two is if you look at quality of life indices. So the ENT literature does, I think, a very good job of looking at quality of life metrics, and they have fairly sophisticated, validated outcome measurements. And what they show is that, you know, the diagnosis of having a vestibular schwannoma is the most significant factor, more than treatment, more than anything else, right? So once you know you have a tumor, you already have a change in your quality of life, regardless. It's going to affect you regardless. It's good, of course, that it's a benign tumor, because obviously we're talking about a totally different paradigm if you're talking about malignant tumors. But within this paradigm, within this tumor, the quality of life indices that are most significant is the diagnosis itself. What they acknowledge is that how does one treat, you know, a patient in terms of quality of life long term? And I think there is where you start to see, I would even say, somewhat equivalence in the long term. It's difficult to be diagnosed when you have certain things which are expected morbidities. But I think certainly for the smaller tumors, there's no question. And I think, you know, caution regarding follow-up is very, very important. So I'll stop there, but very nice job, both of you. And I think both of you did a nice job reviewing literature. And I think it's going to be a challenge too, when you compare best outcome. You know, it's similar to the data when you look at endovascular versus open treatment of aneurysms. You have to get your best practices from your best practitioners compared head to head. So you can't compare, you have to compare high volume centers to high volume radiosurgery centers too. Great. I'll stop on my comments there.
Al, you have any comments?
Always have. Thanks for asking me. Interesting presentations from both. It's a topic that's been discussed now for probably 20 years or more. I've been on, I don't know how many panels with Doug Kanzioka and others, not arguing, but discussing it back and forth. I think a few points that Raj just made need to be emphasized. One, you need to know what the results of your own institution are. And how do you get to be at that level? This is one of the few operations where throughout my years, I did 600 acoustics, and it was not common that I could let a resident do the significant dissection, taking the tumor away from the facial nerve, because that's the heart of the operation, and there's no coming back from injuring the facial nerve. I mean, you can graft it in some patients, you know, JB and I have seen, the results can be quite good, but not as good as leaving it intact. So knowing what your own abilities are and your own institution, I think, come into play a whole lot in what you advise a patient to do, unless they can, you know, afford to go any place in the world and you have the honesty to send them. I think for these middle-sized tumors, it'll be debated for still a while, because as both of you presented, most of the evidence is class C or class 3 evidence. I don't see how you can ever do a randomized study on something like this. Just from your own institution, from a patient point of view, there's some patients that are irrational about the decision they make. For instance, there's a huge Russian population in New York that I had seen, and none of them would have discussed radiotherapy because of the Chernobyl history. And that was just a mindset that you couldn't convince them, no matter how good the evidence was for some of these tumors. So knowing that, I think, is important. Being honest about your grading system and what your results are is key. It's not what the face looks like 2 hours after surgery. It's what it looks like 3, 4 to 5 days after surgery or 2 weeks after surgery when the tone starts to be lost if the facial nerve has been injured. So comparing these results, and looking at literature, it's important to understand who you're reading and how that study was done and what type of meta-analysis and what journal is it being published. Early on, Alejandro, the big study you quoted was a non-peer-reviewed study. And so, it makes a difference on what you're looking at. I don't know that we had the answer. Doug Kanzioka used to be strong in his feelings that hearing preservation lasted longer if you radiated the small tumors even before they became symptomatic, if they were picked up almost incidentally. I don't know that I buy into that, but I've said it before, and I wouldn't want to be quoted on it, but understand the honesty of the person you're reading. Not everybody is as pure in their honesty as you would like them to be and what the results are. I think Doug is. I think Doug is a very straightforward fellow. And he's been my baseline for looking at long-term gamma knife outcomes. And I think they're very, very good. If you look at a study like some of the ones you presented and you're seeing 50 and 60% hearing preservation, I have a real question about that. Having done it myself, and we wrote one of the early papers on hearing preservation. Hearing preservation is not a simple thing to achieve. And when the levels are that high, you're basically talking about tiny tumors that had excellent hearing to start, and tumors that aren't lateral in the canal. The more lateral the tumor is in the canal, the more difficult it is to save hearing. That's not necessarily the same with the facial nerve, but the facial nerve also gets a little bit more precarious when you're very lateral in the canal. If you read a study that has 10 to 20% CSF leak after surgery, I think there's something wrong with that study. There's something wrong with that institution and how they're doing it. So you got to take all of these little things into consideration when you review these studies. But to me, the bottom line is it's the individual or team doing the procedure. I have seen equally bad results from radiation therapy at our own institution. Before Dr. Germano, was doing our radiation, there was a team downstairs that was burning the brainstem, and that whole team was dismissed. So you need to know what your team can do for any modality. And I just think surgery is more surgeon specific than the radiation is radiotherapy group specific. I could be mistaken about that. But there's going to be more information down the road. It'd be wonderful to do a double-blind study, but I don't foresee that happening. So both of you, I thought, review the literature and try to support your sides well, understanding that you may not believe every article you read, but when you're trying to support something, you'll present all the information that is on that side. And no matter what side you want, in arguments like this, you can find literature that'll support what you have to say. It's just whether the literature is really true. I'll stop there.
Thank you. I don't think you can add anything to that. What a really nice set of comments. I thought that your presentations were great. Both of them really poised. You put a lot of work into it. At least it seems that you had to work hard to do such a good presentation. And both very, very convincing. So I don't think you can really pick a winner in this one. Thank you for working so hard to do that. Very well done.
I agree. The effort showed.
Peter, is that it?
Yeah, thank you everyone for your comments and nice job today, guys. See you next week.
Thank you, everybody.